We've got some time for questions. I think you've heard some phenomenal talks on the topic. We've got some microphones through the room, so would welcome any comments or questions.
Want to come up?
Can we turn the House microphones on? And if the speakers can come all up to the table here.
I had a question. You mentioned outpatient echo. Is there a difference between reimbursement comparing outpatient echo with inpatient echo? In other words, a patient on 5th floor admitted for 3 days CHF exacerbation. Is the reimbursement rate for that echo higher than the patient that gets pavilion echo, as part of an outpatient visit?
Why don't we throw that to Dr. Main?
Well, is this on?
I think you push.
Typically, there we go. Sorry about that. Typically, most patients that we take care of in the hospitals are reimbursed under a DRG. So we basically are paid, or the hospital is paid, one lump sum of money for that particular diagnosis. So everything we do in the hospital is essentially a cost. If we do that well and we do that efficiently, the hospital makes money. If we do a lot of unnecessary testing, we don't make money. So, in answer to your question, yeah, there is a big difference. But as several people have mentioned today, sometimes we actually have to invest more to get better outcomes for patients, and sometimes investing more, spending more on the front end actually saves money.
So is there a savings in general by deferring an echo to the outpatient setting? In other words, a patient doesn't necessarily need it, just then and there as an inpatient, and then when the patient follows up, a week or two post-discharge,
well, I think you said something very interesting there. They don't really need it. If they don't really need it, we shouldn't be doing it in the first place, probably. I think that gets back to appropriate use. I think we all see that in the hospital a lot. We get an order for an echo, and they say, the patient's ready to go home. Can you please do their echo so they can go? It's probably not an appropriate use of resources in many cases.
Okay. And then I just have one statement about the presentations, all of which were superb. With regard to the future of medicine, I think we're doomed, just because that slide that had the aging population, where people are living longer into their 90s and so forth, the cost of caring for those patients, the fact that our southern border is a sieve, we have tens of thousands of people coming over, there's no immigration reform, all of these patients will eventually need health care that we will have to pay for. So I think the solution is in the hands of the politicians. I think it's inappropriate for physicians to weigh in terms of rationing of health care is basically what I'm getting at. That's the ultimate answer to this problem, and it shouldn't be the physicians that make a decision, it should be the politicians. So this is something we need to think about in November 2016 when we elect the next president.
Okay, thank you.
To be clear, the silver wave is not due to immigration.
No, it's two problems. One is the aging population. The other is that and I didn't say immigration, I said lack of immigration reform.
Let's let the next person ask a question.
So why don't we go over to the left microphone?
All right, interesting points. Thank you very much for a very vivid discussion. Why am I even charging and billing Medicare and patients' insurances for echoes? Why can't I just let the free market reign, and if I do something better, faster, cheaper than my competitors, I can charge $50, $75, do a good quality study, and then if I find something significant, send the patient for the high-end procedure. And this way keep costs down. If I charge patients a certain rate, that could be reasonable, fine. If they find a better deal someplace else, that could be reasonable too. Why should I use my homeowner's insurance to pay for the landscapers? Why should I use my insurance for my car to pay for gas and wiper blades?
I think that, there is data that using point-of-care ultrasound in defined settings will save money in terms of expenditure. And the key point here is that none of us here are talking about maximizing the physician's income. We're talking about taking the best care of patients.
Sure.
And so it could be that doing a handheld echo on a hypotensive patient and it's totally normal and the patient has septic shock, they don't need a full ultrasound.
Fair enough.
And so it is a possibility and something that I think needs real clear study.
And last question, as a salaried physician, most physicians find themselves at a head-to-head problem with this, because if they have a restriction on ordering certain tests, but at the same time their generation of income is based on productivity, as has been mentioned by colleagues, which is a national issue, that's already an ethical dilemma. So something needs to be brought to bear on that too.
Tim, you have any comments about that?
When thinking about compensation plans for any professional, it turns out that there is no such thing as a perfect compensation plan. Can't be created. And because if you're a professional, then by definition, being a professional as part of a profession, you are obligated to fulfill multiple simultaneous ends in the pursuit of your profession. Different schema have been developed. Some have their 8 pillars of professionalism, and that is frequently cited in medicine. Other professions have categorized them differently. If you take those 8 pillars and think about putting incentives around each of those things, not just one of those things, then you end up with what's often referred to in executive C-suites as a balanced approach to a compensation system. We're moving in that direction. I would say most compensation, even salaried, they're not particularly well balanced. We're challenged in medicine because it's so much easier to measure productivity than it is everything else. So that's only one of the pillars of professionalism. And so the big challenge from a compensation point of view is, as we move, and this was my point number 2 on the 3 things we have to do, we have to figure out how to move towards compensation that balances the broader range of professional goals and not the sole goal of productivity. I will say we've had, I'm optimistic on that score, so even though it's hard to measure some of these things, it turns out there's a lot of good experimentation going on in physician incentives, and I've been very impressed that very small incentives, it sort of goes against what the Wall Street people believe, which is it takes massive incentives to change behavior. Well, maybe it takes massive incentives to change behavior to do something that's unethical. But it turns out that if you're asking people to do what they fundamentally believe in anyway, it turns out really, really small incentives work very nicely. So I think we have a ways to go. I agree that productivity should not be the sole basis for a compensation system. We don't use that productivity as a sole base. I would say we're moving over time to incorporating the other pillars of professionalism into the metrics we use for compensation.
Yeah, if I could cap that a little bit. As an employed physician and just having chaired a compensation committee over the past 2 years looking exactly at this, if you look at Navigant and other sort of compensation leaders out there in terms of designing plans, what you'll find is a diminishing role for productivity over time and an increasing role for these types of metrics. And we moved into that space with respect to our compensation, and we see that role just continuing to increase, particularly as we've got better benchmark data and population health data and so forth, things that are just not nice to do, but that we need to do. So I think that as you're looking at your own plans back home, you're going to see evolution towards this with time.
Dr. Arjema.
Thank you for fabulous talks, very educational session. One thing that I don't think anyone addressed, or at least while I was here, was fear of malpractice. And I think that's an elephant in the living room, because I'm not sure we even think about it so much anymore. There's so much that is done, particularly by our emergency room colleagues, where millions of tests are ordered, and we're in a mindset of not missing anything. It seems to me that that paradigm has to change if we're going to get anywhere, and I wonder what people think about that on the panel.
We have an abstract by Vinay Kinnaid today that showed that fear of malpractice, as judged by a validated scale, is the only thing that predicts whether a physician, cardiologist, or internist will order an echo in patients where it's unknown whether it's appropriate or not. And so we plan to expand that, but that, experience, kind of practice, all those things are unpredictable. It's only whether you're fear of malpractice.
Sounds like an opportunity for a place where we can make a difference. And we have one last question.
Yes, there were a couple of things I wanted to bring up. Number one, I think the RVU emphasis is already having a major impact on education, and the people are not being assessed in terms of how good a teacher they are anymore, as opposed to what their RV productivity is. Number two, one of the reasons the volume in echocardiography has increased so much is, in addition with its maturation and increased utility, it's probably one of the best ways of assessing somebody from a cardiovascular standpoint, and so there's a lot of value for it that accounts for its increased utilization. And number three, which is really very conjectural on my part, but one of the issues that's arisen recently and is starting to get even some political input is, with the advances in technology, a lot of people there are no jobs basically, because a lot of technology is replacing a lot of particularly minor positions. And as the population gets older, there's going to be increased need for both positions to take care of the elder people, and it really is, in a sense, a job source potentially, particularly in view of the fact that jobs where health workers can be used are jobs that would be appropriate jobs for people who are outsourced by technology. So I'd like a comment, particularly on the second one, about the fact that there's been such an increase in echo is that the technologies that provide so much information that from a logistics standpoint and patient management, it's particularly helpful.
But sort of peripheral to that is when you think about some of the echoes that are ordered, if we took the time to listen to the patient with a good history and an exam, we may be able to avoid some of those. But right now, there's because of time and the pressures of time, it's more efficient for you to order the test rather than spend the time with the patient. And I think, again, we're going to have to see some changes in that approach if we're going to reduce test.
Well, I agree with that. And there are times, and I keep on emphasizing on teaching rounds, that you really have to learn how to listen to aortic stenosis because the echo isn't perfect. And if you miss the jet, then you're going to get a much lower estimated valve area. And I've had patients go back and make a second effort at looking at what the velocity is based on what you hear on auscultation. And it's really hard to get anybody to go listen to a patient anymore. They will just assume the echo is the gold standard. And it's a terrific standard, but it's not perfect.
Great. Okay. Is there another? I think we'll do one more question.
Okay, thank you. My name is Sheena Sharma, and I'm in private practice. It's like hard to believe in cardiology. Mm-hmm. And I just wanted to make a comment that what I find difficult that's coming out, and I don't know if it was mentioned, but I didn't hear it, is the importance now, or rising importance of patient satisfaction as included in our outcomes. And I think we should, I'm part of a physician advocacy group, and I think as what you're speaking about today, I find myself in an office seeing someone for benign palpitations, and I don't see these younger patients who are less interested in testing, so I don't know who those people are. I see people that come to me who have a very clear notion of what they want. It's similar to the URI that's viral and they want antibiotics. They don't feel reassured when they don't get a test, and it leads to malpractice, and it leads to issues with patient satisfaction outcomes. And, you have to ask yourself who's running the show, and I don't feel like I think that's a very major issue that continues to crop up as we look at outcomes and who's measuring them. if anyone wants to speak to it, but that was my comment.
Can I try one? Maybe just one. A couple comments. It's a great observation. I fall back on a couple of observations when I think about the significance of what you just said, and one of them is that 50% of healthcare costs every year are consumed by 5% of the population. And that 5% of the population is extremely sick. They, on average, are hospitalized 6 times in the year. That's the average hospitalization rate. So that's the largest chunk of healthcare costs are spent on 5% of the population in any one year. So figuring out in any one situation where someone really wants an MRI for a headache, which is a common one for me, or an echo for palpitations, and you can go through all the protocols and reassure them all you want, at the end of the day, I tend not to deny people something that they are absolutely adamant about where the risk to them is low. Like, why would I deny it to them? It turns out most of those people I can dissuade. A few I can't. And the few that I can't, I'm not so worried at the margin about the one additional echo for palpitations. As an administrator for a very large health system, I would rather do the right thing for the patient, and make that decision on the marginal indication. I am much more focused on the fact that, just from an echo point of view, in my hospitals, we get like daily echoes on people, and usually there's one very specific question, and I just need to know the answer. My clinician just needs to know the answer to that question. They don't need a complete echo every single day on those really, really sick patients. That's a much bigger, so I just want to put it in context. The marginal, like doing the right thing for the patient, even though they're not on the same page as you, that's not a big issue to me. You make the call, you convince them as much as you can, and then you do the test. It's the systematic stuff on the really sick patients. That's where the dollars are. That's where the problems are.
Okay, thank you all. Very good session. I want to thank the panel.